Hello and good morning, my friends. This is Val, and I'm on my exam revision grind. It's week 32, and right now I'm looking at week 9, which was looking at skin cancers, in particular melanoma. And I've just done some revision, and I'm going to take myself back, reteaching myself some stuff, and I'm going to record it just so future me doesn't have to learn everything from scratch like I just did. So yeah, I'm going to take you through some skin cancer stuff today. So starting off with the layers of the skin. So obviously the skin is the outermost layer of your body. It's derived from the ectoderm. And it's made up of kind of, you could say, 3 layers. The epidermis, the dermis, and the hypodermis. Skin cancers arise from the topmost layer, which is exposed to the sun, the epidermis. And as you can see, the dermis is underneath or deep to the epidermis and contains things like our blood vessels and our hair follicles and our sebaceous glands and eccrine glands. So having a look, zooming into the epidermis here, we've got a bunch of layers which can be remembered as come, let's get some beers, which is what every medical student says at the end of the week. The L, you might notice, is not in my diagram, and it stands for the stratum lucidum, which is not as clinically relevant, but it's good to know that it is a layer that happens or is present between the stratum corneum and the granulosum. So in terms of cells that are present in the epidermis, we've got the keratinized squamous stratified epithelial cells up here. We've got a bunch of Langerhans cells, which are our sentinel immune cells that kind of detect bacteria and they detect antigens and they present them to T cells. So they're part of our immune system. We've also got Merkel cells down here, which are involved in detecting fine touch because they're usually situated close to nerve endings. We've got basal cells here, which are kind of the stem cells that mature slowly and eventually turn into our stratified squamous epithelial cells. And we've also got, very importantly, our melanocytes. So melanocytes produce melanin, which is a pigment, and they kind of extend these little tendrils into the stratum spinosum. And melanoma is one of the types of skin cancer that I'll look at, wherein a proliferation of these melanocytes leads to a cancer. Okay, so the greatest, So the greatest risk factor for skin cancers is sun exposure. And so just regarding the types of sun exposure and the types of ultraviolet or UV radiation that's present, there are 3 different types: UVA, UVB, and UVC. So the different types have different levels of penetration. UVC is usually just blocked by the atmosphere, so it doesn't get far past the epidermis. UVB, B for bad, burns. It's actually the strongest. It only really penetrates through past the epidermis and through the full thickness of the epidermis, and it's the one that's most involved in skin carcinogenesis. UVA is also involved in skin carcinogenesis or skin cancers. It's 95% of UV radiation, but it's actually more associated with aging. So A for, aging. And by aging, I mean things like wrinkles, which we try and do our skincare to prevent. So when we're putting on our, skincare sun cream, we're trying to prevent all of these forms of UV from going through and damaging our skin. Regarding skin cancers, there are 4 main types. The most common is basal cell carcinoma, which comes from the stratum basale, or the follicular epithelium of sebaceous glands. The second most common skin cancer is the squamous cell carcinoma, which comes from the stratum spinosum and above. And the third most common is the well-known form of skin cancer called melanomas. We've also got Merkel cell carcinomas, which I'll go through right at the end. And those come from our Merkel cells. Alright, so regarding our melanomas, there are certain risk factors which make someone predisposed to melanoma. So a risk factor is being a man. Sorry, people. And also the obviously exposure to sun without the use of UV protective clothing or sunscreen, as well as solariums or sunbed use, which has now technically been banned in Australia. If you have a high freckle density, immunosuppression, for example, due to chemotherapy or diabetes, a history of previous skin cancer, and a history of atypical nevi or weird-looking moles, that makes you more predisposed to cancer. Additionally, if you have what's called Fitzpatrick skin type 1 or 2, which means that you might have blonde or red hair, you might have blue eyes, you might burn easily, or you're fairer in color, that means you're also more susceptible. As opposed to someone with Fitzpatrick skin type 5 or 6, where they are more tanned, they have darker skin, darker hair, you would be less at risk of melanoma. Now, in terms of the pathophysiology of melanoma, obviously it starts with our melanocytes here. And what actually happens is you get this progressive atypia of melanocytes. So our UVB and UVA are going to come in, they're going to damage our DNA by introducing UV-induced pyrimidine dimers in the DNA. And if our DNA fails to repair this pyrimidine dimer, that's going to lead to the increased expression of oncogenes such as BRAF or NRAS, which are here, and this leads to uncontrolled melanocyte proliferation and hyperplasia. This can lead to the development of an in situ melanoma. In situ meaning it hasn't crossed the basement membrane, it's still just chilling in our epidermis. And then if this continues to progress, it can eventually lead to an invasive melanoma, where it passes the basement membrane and invades into the subcutaneous tissue. So here we have the epidermis. A carcinoma in situ would be sitting in the epidermis and would not have passed the basement membrane, whereas an invasive melanoma would have passed the basement membrane and started to invade towards where we see our blood vessels, and I didn't draw one here, but also our nerves. So, in terms of clinical features, what we're going to be seeing within melanoma can be split using the ABCDE approach. Basically, a higher level of each of these factors indicates a poor prognosis for the melanoma. So if it's asymmetrical, that is, if you divide it in half and one side looks different to the other, that's pretty bad. If the borders are irregular, and if the borders are poorly defined, if the color is not uniform, for example, how do you used to say, red and brown makes you frown. So that's why I added some red here. Just a little touch. D for diameter, more than 6 millimeters is not good. And E, very importantly, is evolution. So you could have a dysplastic nevus or a weird looking mole, but it's stayed the same your entire life and you've had it since you were a kid. That's much less likely to be cancerous than something that's changed within a month. Or changed in terms of symmetry, borders, color, and diameter. In terms of subtypes, there are a couple of different subtypes, which aren't too important, but I guess good to mention. The most common subtype of melanoma is the superficial spreading melanoma. This usually arises from a pre-existing nevus and is the most common type. The most aggressive subtype is the nodular melanoma, and these kind of bulge out of the skin like that. hence the name nodule. And so they have a really large vertical as opposed to horizontal size. You can also get lentigo maligna and acral lentiginous melanomas. Acral is referring to the fact that it can appear on your palms and on the soles of your feet as well as underneath your nails. So you might have heard of melanomas that appear under your nails, and that could have referred to acral lentiginous melanomas. In terms of grading and staging of melanomas, there are a few different things to note. So grading refers to the microscopic appearance of the cells and how undifferentiated they look, as well as how much they've kind of invaded microscopically, whereas staging refers to how much of the rest of the body is involved. So there are a few negative prognostic factors, aka factors that make it look not so good if you have melanoma, and these can be remembered using the mnemonic, too many underage guys cite Clark. I don't know why these underage guys are citing Clark, but Clark is one of the grading systems. Oh, I'm gonna add in a little. Oh, ignore me. There we go. Okay, so our negative prognostic factors include tumor thickness, mitotic rate, ulceration, a higher age, male gender, and specific sites, which are listed here, as well as an increased Clark or Breslow thickness. So what is Clark and Breslow thickness? Let me explain. So Clark thickness measures the level of invasion, whereas Breslow thickness is just the thickness in millimeters. So a Clark's grade 1 means that it's sitting in the epidermis, whereas a Clark grade 5 means that it's invaded into the subcutaneous tissue in between, so that's like kind of moving through our different layers. So Clark stage 1, Clark stage 2, 3, 4, and then into the subcutaneous tissue 5. Our Breslow thickness ranges from 1 millimeter all the way up to more than 4 millimeters. And so that's our grading, our microscopic grading, which can be determined through taking an excisional biopsy of the skin, of the lesion. It's noted here, well, I wrote down that it's not as good doing a punch or shave biopsy or a needle biopsy because you're unlikely to actually get clear margins from this. So you want to full on, measure out your margins around your, around your melanoma, and then do like a nice deep excision in order to get the grading of the melanoma. In terms of staging, they use the tumor, node, and metastasis, so the TNM staging, and it ranges from 0, where you have an in situ melanoma, all the way until stage 4, where you have a metastatic melanoma. Now, the next type of skin cancer is the squamous cell carcinoma. So this is the second most common skin cancer after the basal cell carcinoma, and it has a bunch of different risk factors, of course, in addition to sun exposure. So for our guy here who has a squamous cell carcinoma, you can see that, again, he's a guy, and he's pretty young. He's looking about less than 40 years old. He may have used a sunbed and been exposed to sun. And other risk factors that are specific to squamous cell carcinoma include ionizing radiation, chemical carcinogens, chronic ulcers, and old burn scars. Pathogenesis-wise, actinic keratoses can actually turn into squamous cell carcinomas. So these are a type of skin lesion. And once the squamous cell carcinoma starts proliferating, the in situ disease, unlike melanoma, instead of just being melanoma in situ, this one is called Bowen's disease, where it hasn't passed the basement membrane yet. Once it started to invade, it's known as an invasive squamous cell carcinoma, and then it can metastasize through lymphovascular spread. And so the way that someone might present with an SCC is they might have a lesion on their face, and they might also have like a swollen lymph node somewhere because of the lymphovascular nature of the spread. So as well as metastasizing to regional lymph nodes, it can also, in more extreme cases, metastasize to the lungs, liver, brain, and bone. In terms of locations of sun exposure where squamous cell carcinomas are most commonly found, you can see them on people's faces, such as their lips, their scalp, their necks, and their arms. And this is what, gross, a squamous cell carcinoma looks like. So characteristic findings include induration or ulceration. They're very hyperkeratotic, which is why you can see it's kind of scaly here. They're usually tender and erythematous, which is that redness due to the increased vascularity. And they tend to be scaly, and yeah. I think you can also note that sometimes they have telangiectasia, which is where you get like red blood cells, but you don't, dilated blood vessels, but you don't really see that in this one photo. All right, third skin cancer. We've got the basal cell carcinoma, which is our most common skin cancer, but luckily it's rarely invasive, so we don't worry too much about it. Or we do worry about it, but it's not as like pressing to get it removed. So basal cell carcinomas arise from the stratum basale of our skin, of our epidermis, or the follicular epithelium of our sebaceous glands. Basal cell carcinomas arise in people, mostly males again, above 40 years old, people with a Fitzpatrick skin type of 1 or 2, high freckle density, immunosuppression, can be caused by X-rays, which is very interesting. They usually appear on the mask areas of the face, so that is everywhere except for the eyes and the lips. And they can also appear in the neck, trunk, and hands. Oh no, my iPad's running out. In terms of invasiveness, these ones usually can invade perineurally. So say you've got a basal cell carcinoma here. What you might be worried about is the spread of this cancer to other parts of the face, along the roots of certain nerves. So basal cell carcinomas can cause pretty gross deformities in people's faces. There are two types of basal cell carcinomas, nodular and superficial, and you can see that they just have different 3D structures. And characteristics include shiny, translucent, telangiectagic, again, those like spotty blood vessels, and very importantly, this is how I find it useful to differentiate between these, we've got these rolled pearly edges. So see how it's kind of like lumpy and shiny, reflecting it, the light on the edges? That's what makes it more basal celly. Yeah. In terms of management, and this is for all of the types of skin cancer, you can do surgical excision, sentinel lymph node removal or lymph node clearance, immunotherapy, chemo or radiotherapy, education, counseling, and eye care. And then finally, just before I forget about it, we've also got our Merkel cell carcinomas. So our Merkel cells were those cells that are involved in detecting fine touch. These ones are wild. They're like so rare, but they're so scary. They literally have a 5-year lower survival rate than melanomas, and 50% of them are incurable upon presentation, which is pretty sad. So I guess in conclusion, put on your sunscreen, and yeah that's it. Oh my gosh, that was good. I haven't put on my sunscreen today, and it's looking real sunny outside, so I might go outside and reward myself for studying skin cancer. Thank you again, guys, for listening, and I hope you have a great day. Goodbye.